of normal, again, is that 40, the upper limit multiplied by 3. If it's more than 120, do not start 3HP. You need to evaluate further for liver disease and only initiate once ALT is normal, or once the cause of the rise in ALT has been identified and managed. During the 3HP treatment itself, we need to ensure that we continuously screen for active TB disease. Colleagues, it's important to note that just because we have provided latent TB infection treatment to an individual, it does not mean that they will not develop active TB disease in that period of treatment. If the TB disease, I want to use a loose word, if a person was 5 to developing TB disease, already the bacilli were multiplying, had become active, 3HP might not actually halt that multiplication and progression to active TB disease. The same even goes for INH monotherapy. If someone was already in the process of multiplication of TB disease or of TB bacilli towards the development of active TB disease, providing TB in latent TB infection treatment will not stop the process. So it is important, it cannot be stressed enough, that at every client contact visit, we need to ensure that we are screening for development of active TB disease. We've already spoken about the issues around contraception. So we need to make sure that our clients are counseled about pregnancy and the use of additional barrier contraception prior to initiating 3HP. We also have said, as they proceed, they continue with treatment, we continuously look for signs of liver toxicity or hypersensitivity. And if we find them, we have discussed in the previous presentation how to manage the different severities of symptoms. We also need to continuously ask about peripheral neuropathy. We know which drugs we are providing for the client, and we know what are the side effects and what adverse events we can anticipate from these drugs. This has also been shared, this slide, you are seeing it for the second time, colleagues. I'm just re-emphasizing, remember, the drug reactions are rare. The severe ones are even rarer. So we should know about them and we should look out for them, but we should not be paralyzed by the fear of drug adverse reactions, because we know they are rare, we know what they are, but we also now know how to respond if these drug reactions should occur. And we know that if there are severe drug reactions, we need to refer our clients to a higher level of care. So colleagues, the issue of drug adverse reactions, we know about them, we anticipate them, we identify them in time, and we manage them timeously so that we do not expose our clients to unnecessary harm. And on the slide that, on the bottom of the slide, we are just reviewing some of the signs and symptoms of severe drug reactions that we need to look out for. This slide, we present what could possibly happen while someone is on 3HP. And one of the things we have already alluded to is the development of symptoms of TB. Should the symptoms of TB develop, or should someone be diagnosed with active TB disease, discontinue the 3HP, investigate them, and treat them for TB if they are positive. And do not forget to close the loop by conducting TB contact tracing and management in all those who are diagnosed with active TB disease. Should the client develop malaria while on 3HP, we can continue 3HP if there are symptoms or if the malaria is not severe. Remember the drug interaction presentation, we spoke about the the interactions between rifampicin and the anti-malarial drugs. So you can continue if it's not severe. However, if the client presents with severe malaria, discontinue 3-HP because you risk reducing the efficacy of the treatment and again exposing the client to unnecessary danger. If the client should fall pregnant while on 3-HP, for now, colleagues, while we are waiting for confirmation of or data, confirmatory data from studies that are underway, we need to continue to discontinue the 3-HP, and we will discuss the options of completing a latent TB infection treatment with the client. We will also monitor the CD4 count or check for the latest CD4 count from our stationary to decide if the pregnant woman should be switched to INH monotherapy or if LTBI treatment should be stopped altogether. Colleagues, remember that for pregnant women with CD4 counts less than 350, INH monotherapy would still be an option for this woman. If there is a change in chronic medication that the client is on, or they are diagnosed with they are diagnosed with a different condition and they are put on new medication, colleagues, ensure that you document the type and dose of the concomitant medicines. Check for drug interactions between what they are on, the 3-HP, and the new medication that they've been initiated on. Only continue 3-HP if it is safe to do so and there are no absolute contraindications to administering 3-HP with the new medication or in the context of a new diagnosis. To just sum it up, colleagues, let's remember that for every client contact visit, when the clients come to you, you always have to screen for active TB disease, screen for development of adverse reactions, and assess for tolerability of the regimen. Assess adherence and provide support as appropriate. Colleagues, in terms of adherence, it is important that we educate our clients to know what we are treating to start off with, what is the benefit of staying on this treatment, and for them to understand what adverse reactions to look out for and how they should be managed or how they should present to the clinic or to us should these different reactions occur. We also need to make sure that at every visit we assess for new medications that can interfere with 3-HP, and remember to repeat ALT for all clients who had a raised baseline test. Remember just before the fourth dose, and advise the client on missed doses. Colleagues, it's very important for us to exercise sound clinical judgment when we are handling our clients on latent TB infection treatment to ensure that the benefits of our treatment actually outweigh the risks. So we should not expose our clients to unnecessary harm. This slide you also saw, colleagues, just to re-emphasize that if a client develops symptoms of liver damage or severe hypersensitivity, they should not take any further doses of 3-HP. And we need to make sure that our clients know this information. We counsel them on how to identify or what to identify as signs and symptoms of liver damage or severe hypersensitivity. We make sure that they understand if all these signs or some of these signs or symptoms develop, they should not take any further doses of 3-HP, and they need to know which healthcare provider should be contacted for advice as soon as they experience some of the signs and symptoms we have educated them about. They also need to be clear that should these signs or symptoms develop, they only need to continue 3-HP once the healthcare provider advises them that it is safe to continue with their medication. We also need to ensure that our clients are clear about when to contact their healthcare provider. And some of the advice that we should make sure is clear to our clients is that they need to contact us if they have any persistent or concerning symptoms that we would have educated them about. If there is any change in their health or medical situation, we've already discussed this, if there are new drugs or new diseases, so that the efficacy of the regimen or of their other treatment is not tampered with. Change in social situation, Dr. Mawela already alluded to the moving away and ensuring that clients are in an area where they can access the 3HP. Some clients complain of gastrointestinal discomfort. So where there is issues around food security, you need to ensure that your clients do alert you so that you can link them up with the different social relief programs that are available. Before we conclude this section, colleagues, I would like to just touch on some of the barriers we encounter when it comes to diagnosing and diagnosis and treatment of latent TB infection. These factors, some of them are healthcare provider or systems related, and some are client related. Please note that this list is not exhaustive, colleagues, but I've just highlighted some of the factors that I also thought are very much within our control, that if we are able to deal with these factors, we will ensure that the program achieves the success that we would want. Let me start off with the health provider related factors. We know that for as long as we've implemented TB preventive therapy, starting from when we were just implementing INH preventive therapy, we've always come across unwillingness of healthcare providers to prescribe latent TB infection treatment. And this has been quite a big stumbling block, particularly, as Dr. Mawela said, particularly in the case of our colleagues, doctors. There's been very, big but unfounded fears of facilitating the development of drug resistance with monotherapy, and uncertainty with regards to the potential benefits of the preventive treatment versus the potential risk of adverse events. There's also been issues around people not being trained or experienced in providing treatment. Colleagues, we are hoping that with this workshop, we have covered most of the concerns that I hope we have covered all the concerns that I've put up here as health provider related factors. Colleagues, we have spoken about the rationale for LTBI treatment. We've spoken about the drug interactions. We've spoken about adverse events. So the training has been done. We've addressed issues around resistance. We've shown you the risks. We've shown you the benefits as well. So colleagues, we hope that after this training, these factors are not going to be problematic when it comes to initiating latent TB infection treatment. We know that the health provider and the healthcare system are not the only barriers. There are also client-related factors, and amongst those factors, some of those that I've highlighted include unwillingness of people with LTBI to undergo a prolonged course of treatment for an asymptomatic condition that may never progress to active TB disease. Colleagues, remember our regimens, we've had INH for 6 months at some point, then recently our INH, we are giving it for 12 months. So indeed, it is a prolonged course of treatment. But colleagues, 3HP offers us an opportunity to provide a very short course of treatment that is also very effective. Another factor I need to talk about is the understanding that our clients have when it comes to starting on a latent TB infection treatment. We have talked much about TPT and LTBI treatment. Colleagues, what we are trying to get at this point is for everyone to understand that what the aim of this program we are on is to treat latent TB infection. It's not just taking a drug to prevent, but there is infection that has taken hold in the body that needs to be treated. And we hope that after this workshop, you will be able to relay to the client what it is exactly are we trying to achieve with this treatment. And when they understand what it is that's being treatment, we hope that it will assist them and also assist us to have better completion, better uptake and completion of latent TB infection treatment. The pill burden, you know, so some clients complain about the pill burden. Colleagues, we are just waiting patiently. In no time, we will have the fixed dose combination of 3-HP and INH. And with that, we'll be able to reduce the pill burden. But again, colleagues, even if we are still on the single drugs, remember now, one is not taking, the client will not be taking the treatment every single day, but this is just once a week. So colleagues, I hope you will be able to make the client understand that much as at this point our treatment is not in an FTC, but at least we have shortened the duration of treatment without losing efficacy, and we are only asking for the client to take the tablets only once a week. Colleagues, I'm going to stop there. And before I conclude, let me just go through what are the key learning points from this section. It's important to monitor clients monthly, screen them for TB symptoms at every client contact, make sure you educate them about adverse reaction detection, and also address factors that could influence adherence. And I repeat, colleagues, understanding why a client is being put on treatment will help them to stay the course or to complete the course of treatment. And also, colleagues, please check for drug-drug interactions. Please note that on the chart, there is a link to the interaction checker. Please follow the link, colleagues, and just check it out. It is very easy. If you have a smartphone, this will be the easiest way to check for interactions very quickly. With that, colleagues, I'm going to end this section. Dr. Mawela, I hand over to you again.